Good evening, and thank you for registering and attending this webinar. My name is Osha Turner, and I'm a brand manager at Henry Schein. Henry Schein is the exclusive distributor of Calmix, and I'm very pleased to introduce your two presenters. Professor Laurie Walsh and Dr. Teoh will be speaking tonight about improved endodontic technologies with a focus on materials and techniques that you can use to produce better clinical results. Professor Walsh has an Order of Australia. He is the research program leader for advanced materials at the University of Queensland School of Dentistry. In this role, he leads research projects that explore the performance of new materials and techniques. His research interests are in advanced technologies such as lasers and biomaterials and in dental microbiology, and he has had a particular research interest in endodontic materials. Your second presenter, Dr. Teoh, is currently completing his specialist training at the University of Queensland. He is in his third and final year. Prior to commencing his specialist training, he completed a research master's degree under the supervision of Laurie, studying new types of antimicrobial medicaments and endodontic cements, using both conventional microbiological methods and confocal laser scanning microscopy. We hope you find this webinar informative and useful.
Thank you very much, Azra, and it's a great pleasure to be able to speak with you all this evening. In my part, I'm going to go into some of the science which underpins the way that we understand calcium hydroxide today. And this takes us back just almost 20 years ago when I began working with Basil Athanasiadis and Paul Abbott, reviewing what we knew about calcium hydroxide medicaments. The first paper we wrote has already had over 400 citations in the literature, which means it probably did say a couple of things that were useful. So what do we know about calcium hydroxide? We know it's a very powerful antimicrobial agent because the hydroxyl ions it produces can penetrate into bacterial cells and into biofilms. They can kill bacteria and fungi in a way that they can't develop resistance to, and of course it can also trigger hard tissue repair. More recently, we've learnt that calcium hydroxide also has some immunomodulating effects. It can turn down some of the acute inflammatory components that are driven by things like bacterial lipopolysaccharide. When we think about calcium hydroxide killing bacteria, we have this concept of critical pH, not critical pH like enamel, but a critical pH in order to ensure a lethal effect. And for most bacteria, that level is around about 10.5. For some very tough customers like Enterococcus faecalis, the pH threshold is actually higher, closer to around about 11.5. And it sounds pretty simple that if you use an alkaline material like calcium hydroxide, you should be able to kill organisms. But the problem is when you put it in teeth, the dentine buffers the pH and it lowers it down. And this happens in the tubules and in the dentine, which means that limits the antimicrobial action. Now, the idea of using calcium hydroxide in teeth is an old idea. It goes right back to the 1920s. I first started playing with calcium hydroxide in 1970. It was the very first chemical I picked up out of my very first chemistry set when I was an 8-year-old. So what have I learnt about calcium hydroxide in 50 years? Well, first of all, it's not very soluble in water. When you put calcium hydroxide in water, less than 0.2% of it dissolves at normal body temperature. The rest just simply sits there in an inert way. Not only that, but carbon dioxide from the air, which dissolves into the water, begins to form calcium carbonate. And this reaction basically limits the ability of the calcium hydroxide to do what it's designed to do. Many people who have made calcium hydroxide materials have simply put a large amount of calcium hydroxide in to their particular paste or gel. And you can see here, summarized from one of our papers in 2010, the sort of levels that you might find in a range of different commercial products, from around 30% to nearly 50%. But most of this is actually not going to be available because it's basically insoluble. because so little, less than 0.2%, can actually dissolve into water. And this has a big implication on how alkaline the environment is that you can achieve. We know that traditionally when you put calcium hydroxide into water, you get a pH of somewhere around about 12.5, maybe up to about 12.7. And if you look at calcium hydroxide paste, and there's a whole range of different brands listed on the slide here, when we measured their pH, you can see they're all about 12.5 up to slightly higher, about 12.6. In other words, the real measurements match what we would predict from the chemistry. And there's another little problem, and that is when you put a calcium hydroxide into water, you're putting a hydroxide into a hydroxide, because water contains available hydroxyl ions as well as protons, hydrogen ions. And you might have remembered learning in school in chemistry about a thing called the common ion effect. In this case, the common ion is hydroxyl. It's very hard to get it to dissolve. So having understood these problems, the solution, in fact, is so simple that it's obvious, and that is you take away the water. And this idea we had about 10 years ago, Basil and I. And if you want to read the story of what we did and the details of how it works, then you can look at any of our patents, either issued or the ones that are pending. There's a number listed here on the screen. Let me take you through it in a fairly painless way. The basic idea is by getting rid of the water and choosing some other solvent, you get something where the calcium hydroxide can dissolve better. You get rid of this common ion effect, and therefore you achieve more dissolution and therefore more release and a higher pH. It's a fairly simple concept. And we first presented that in public at an IDR meeting in 2014. We actually have looked at a whole range of different solvents, and our patents cover a large range of solvents. But the one that happens to be in Calmix is a special copolymer blend of two forms of polyethylene glycol. And they give the material not only its optimal pH characteristics, but also its viscosity to allow it to be able to be delivered well into the root canal environment. Every other product in the world, in fact, uses water as the solvent rather than polyethylene glycol. A couple of products around the world, mostly in the southern hemisphere, sometimes even blend one type of polyethylene glycol with water, but none of them can actually do what this special formula can do. So what is polyethylene glycol? Well, you've probably used it hundreds of times without knowing it, because it's the base of many cosmetics, lotions, creams. It's used for many systemic medicines, particularly antiviral, because it's an extremely good solvent material. It's incredibly safe. It's one of the few things that's listed as generally recognized as safe and is approved to go internally. And it's been around for a very long time as a pharmaceutical excipient or a carrier. So what's so special about it? Well, it's all about where the electrons like to cluster. In a water molecule, the electrons like to cluster as shown in the diagram here, slightly to either side of the top of the oxygen atom. But in polyethylene glycol, they distribute over the surface in a very unusual way that makes it extremely good for binding calcium and therefore for releasing hydroxyl ions. And these two little illustrations come from our 2016 presentation, showing where this special surface actually is. When you test the ability to release hydrogen and to release hydroxyl ions, you can do this using, of course, titration, something you would have remembered from senior chemistry. So in this particular study, we simply used a titration experiment to measure the amount of hydroxyl ion release using the polyethylene glycol solvent, and we were able to demonstrate it was much higher than what you could achieve even with a fully saturated solution in water. Now, there's over a dozen different published articles and presentations on this type of chemistry, and I'm not going to go through all of them. Just want to pick out, though, a couple of key points. From a chemical perspective, if we can get a higher pH at baseline, we should be able to get more hydroxyl ions to go into dentine, and therefore we should be able to kill more bacteria and deeper in the structure of the dentinal tubules. In other words, to reach some of the endodontic bacteria that penetrate deeply. Ideally, we should be able to kill the toughest organisms, which are the fungi. And from a clinical perspective, it would be good to have something that was much more radio-opaque, that didn't dry out, that didn't stain, that didn't weaken roots, and was really easy to remove with some fairly simple irrigation. So all the 11 things on the screen, there has been research conducted around, not only by myself, but also by many other people who have experimented with this material at different universities and also in commercial laboratories. So let's just do something very simple. Let's just take a pH electrode and put that into a couple of common materials, Calicept, Pulp Dent, and Calmix. And you can see straight away the difference in the pH reading. Now, some of you might know that there are special electrodes that are made for reading the pH of things that have very low or zero amounts of water. And this is a special type of non-aqueous electrode. So you can see a regular electrode for pH measurement on the left and a special one on the right. So let's go back and use both electrodes and see what you can find. This is from a presentation in 2006. And I want to begin by just focusing on one little area, which is the area around the pH of about 12.5 to about 12.7. So this is the typical range, and that's exactly what we measured for the traditional calcium hydroxide materials. This one has water with some PEG. But notice what happens in polyethylene glycol 400. There is a beautiful relationship as you increase the calcium hydroxide with the pH. And when you use the copolymer, you're able to achieve an incredibly high pH, in fact, at a slightly lower calcium hydroxide concentration because of the special solvent accessible surface that I showed you before. Now, if you're a bit confused about seeing a pH value above 14, don't be worried about that. The pH range in water goes from 1 up to 14 at room temperature. However, when you go to a different material, which is not water, the pH range is actually quite different. So in a PEG co-solvent, you can actually get quite high pH values. So this is some of the excellent work that Teoh did during his research master's degree. We worked out a way to actually watch the hydroxylines move through the tooth structure by using a multicolor anthocyanin pH indicator that was infiltrated into the roots. So what you're seeing on the screen here is a cross-section of a root with a series of measuring points. And literally the root structure changes color according to the pH, and then you can analyze the color by using some digital image analysis. This was published in a high-impact materials science journal in 2018. So if you look at the root before the paste is put into the root canal in the center, you can see this sort of dark purple stain caused by the anthocyanin dye. And then over 2 weeks, you've got this blossoming effect of color change. And if you look at the reference table below, you can see that there's been this alkaline wave that's particularly concentrated around the inner parts of the dentine. And it basically dilutes out as you go to the outer part of the root where the pH is close to neutral. Now, this study, which was done at the University of Western Australia, used a slightly different method with microelectrodes, but they basically found exactly the same thing, that the Calmix treatment gave the highest pH in the inner dentine, that's the green arrow, and it also achieved it in the fastest time compared to other types of materials, like, for example, Pulp Dent or Calicept. And if you look at the pH plots, you can actually see visually this range of pH. The red arrow indicates the red curve, which is the wave of pH caused by these hydroxylines running through the inner part of the dentine. Now, if you're worried about what happens when they reach the outer part of the dentine, then you don't need to worry because, in fact, the pH values are exactly the same over the period of time. And this is because of the buffering effect of the dentine in the outer part of the root structure. Well, what about killing bacteria? In this particular study, the challenge was 400,000 either Ephecalis bacteria or Candida albicans fungi. So the maximum possible kill that could be recorded was a log kill of 5.6, which was seen with Calmix and also with Pulp for E. faecalis. But the really neat thing was the killing of Candida albicans, which is a really tough nut. And that was better by more than one log, so more than 10 times better than for a conventional calcium hydroxide material. This test was not undertaken, by the way, by myself. It was done using a blind analysis in a commercial laboratory. Here's another way of thinking about it, and this is, again, a different independent test which was done, which measures the minimum bactericidal or fungicidal concentration. And this is incredibly low for Calmix, meaning it's a very, very good antifungal agent as well as an antibacterial agent. By comparison, the MBC for pulp dent or for other materials like odontocide is very, very much higher, multiples of times higher, indicating that it's actually a better fungal material. Now you might be thinking, if it's very alkaline, wouldn't that possibly be harmful to tissues? And the answer is actually quite surprising. It's all to do with the rate of release. And the way you test this is using a special type of cell culture method with kidney or Vero cells as they're referred to. And this is a standard way that's used around the world to assess cytotoxicity in cell culture. And you can see the scoring system here. Well, when you actually rate the cytotoxicity of Calmix and you compare it to Pulp Dent or to Ultracal, it actually turns out to be less cytotoxic by a factor of about twofold. And it's all to do with the fact that the release is actually in a more gradual way. And this is because of the way that the solvent accessible surface of the polyethylene glycol copolymer releases the molecule. It's really quite a neat system. Here's a clinical example of the hemostatic effects, in this case on some soft tissue around this particular root fragment over a couple of minutes. And here's a similar example before and after around a crown preparation. And you can see this slightly chemical astringent effect on the surface, which you see with all types of highly alkaline materials. Something which has been raised about alkaline materials is a belief that they might actually weaken the root structure of teeth. This was something that I can remember being taught as an undergraduate student, and it turns out, in fact, not to be the case. Bill Kaler, who's an endodontist in Brisbane, who's worked with me and with a number of grad students of mine over many years, Bill studied tooth fracture in his master's and in his PhD. And he undertook this independent study where he used lamb incisor teeth to look at what happens when you put different sorts of calcium hydroxide materials inside them. And this was published in the Journal of Endodontics. And what Bill found was that when you looked at teeth at 3 months or 6 months or 9 months, there was actually no difference between Calmix and the just negative control, which was saline. And in fact, there was no effect of Ultracal or Calicept either. And in a later review paper, he was able to explain why the whole idea of calcium hydroxide weakening teeth actually comes from some flawed interpretation of some early research. So it's something we've had to go back and rethink. Finally, before I hand over to Yao, who's going to take you on a much more sort of clinically focused journey, I just want to make one comment about something that always annoyed me about calcium hydroxide materials that I'd used in the past, and that was you couldn't see them on radiographs very well. Some materials began to incorporate radiopaking agents like barium sulfate to do that, which is not the way that it's done in Calmix, by the way. A different type of agent is used. But in fact, it's the most radiopaque of the calcium hydroxide materials that are currently in use around the world. And you can do this very simply by making standardized samples and then running them against an aluminium step wedge to calculate out their aluminium equivalent, which is what was done in this study here. And when you analyze the radioopacity, which is the grayscale value, Calmix is the bar shown in yellow here, you can see how that's superior by a small amount to Pulp Dent and Calicept, and it's considerably more than Ultracal, and it's about 5 times as much as for materials like odontocide. And all of those improvements are actually statistically significant. There are some other components of the clinical handling that I won't talk with you about, But I want to now pass over to Yao, because Yao's going to give you the insight into this area of technology and how it's used from the point of view of someone who's getting towards the end of specialist endodontic training. I'm certainly no endodontist despite my interest in endodontic materials, so it's really important that you get a chance to hear from Yao about how he has thought about this over the last 6 or so years. Thanks very much.
Thanks, Laurie. When I started my journey with Laurie regarding this material, I studied the research aspects of it on the scientific side. And later on, when I went into the clinical side of things in endodontic training, I started to realize that, there's a lot more to it just into a material, not just from the scientific point of view, but how can we bring this into the clinical aspects and how can we improve our daily lives? So basically, this material is something that I've worked with for a while, and I've started to gain a few things which I'd like to share with you guys today. So first of all, let's go through what are the endodontic goals. Basically, in a nutshell, endodontics, the aim of it is to eliminate the infection within the tooth, and following which we seal the root canal system. But before we seal the system, we need to eliminate the infection, and that means reducing the bacterial load or the bioburden per se down to a level that our body can deal with it, so that our body's immune system can fight it and can maintain a good relationship. So in other words, how do we do that? We do that by removing bacteria through preparing and shaping, irrigation. But a big component of it is still using some sort of an intracanal medicament. And studies have shown throughout many, many years in the literature that significant bacterial load has been reduced with the use of calcium hydroxide dressing. This has been done since well before the early 90s. But some of the latest studies have also shown, even today, calcium hydroxide use has shown that you can reduce bacteria by a significant amount. And this is not just shown through microbiological studies, but through histological studies as well. So there are a lot of histology studies where they actually extract the teeth and look at them under a microscope, and they find that, by using intracanal medicaments, we actually reduce more bacteria than when you do something in a single visit. So it's a very good study out from from Domenico Ricucci's group. They do excellent histological slides. And you can see in this image that in the one visit group, okay, the bacteria are usually stained purple in color. And in the two visit group, you'll see debris in the canal, but you don't actually see bacteria per se. There's no way to completely bacteria, but the aim is to sort of bring it down to a level that our bodies can deal with it. That's the whole point of endodontic treatment, so that you don't elicit immune response. So some of these images are actually confocal images from our research group at the University of Queensland, and these teeth have actually been prepared using rotary systems, and they've actually been irrigated or irrigated with hypochlorite, and the irrigation has actually even been activated by lasers or ultrasonic irrigation or something to sort of agitate the fluid. And you can see that despite everything that's being done, we can't clean the isthmus area. These areas are just near impossible to clean at times because we just can't physically instrument these areas. Secondly, we see that in certain canals, yes, you are instrumenting these canals, but not everything in nature is a perfect circle. And unfortunately, our rotary files produce a circular shape. So there are times that you don't actually clean the entire canal wall, and studies have shown that only about 2/3 of the canal wall is actually being touched by your rotary files. So we do rely on a whole lot of other things, again, like irrigation, activating the irrigants, to sort of remove this bioburden or this bacteria within the canals. So, when you look at these images, it sort of makes you think that, putting down a file, prepping the tooth, and irrigating, I'm not sure if that's actually enough to kill everything. And that's why we have to take a back seat and go back to intracanal medicaments. So by using an intracanal medicament, the idea is to try and kill the bacteria over time between the different visits that we have. So when we look at intracanal medicaments and we break it down, there's pretty much two broad categories that we use. We've got the antibiotics, and that antibiotics sort of kill bacteria in a way that it either inhibits bacterial growth, and that is usually through clindamycin and tetracyclines. These are the common antibiotics that we tend to find in some of our paste that is mixed in with a bit of steroid. So you've got clindamycin in odontopaste, and you've got tetracyclines in Letamix. So these kind of medicaments, they don't kill bacteria, but they sort of inhibit bacteria from replicating and growing. You've got your stronger bacteria antibiotics, such as penicillin. Those end up actually killing bacteria, but those we don't really put them into canals as much in terms of medicaments. So in a nutshell, antibiotics kills bacteria, but discriminately. There is some inherent resistance. We all know about antibiotic resistance, and we can see that some, especially clindamycin, there is some sort of inherent resistance towards certain bacteria, such as Enterococcus faecalis, like Laurie mentioned earlier. So when we come down to calcium hydroxide, it works slightly different. Instead of killing bacteria discriminately or selectively, it works in an indiscriminate way. It just works on a very, very high pH. So it sort of exerts a similar effect across the spectrum. So from all kinds of bacteria, be it gram-positive, negative, anaerobic, and Laurie's also shown you in terms of fungus, Candida albicans. That's how it works too. So it generally works by becoming so alkaline or basic that it just breaks down the cell walls, or it causes the cells to burst at times. So in other words, with calcium hydroxide, you don't actually have resistance. The bacteria, it works by having a very, very high pH, and bacteria doesn't really learn to grow or learn to defend itself from it. And as Laurie mentioned earlier, calcium hydroxide actually reduces or blocks some lipopolysaccharides that are being produced by gram-negative bacteria. And this actually stops them from triggering interleukin 1 and 6, which sort of induces an acute inflammatory reaction. So that actually helps to reduce some sort of inflammation as well. The hydroxide ion, that's the portion that we're looking at. The hydroxide ion, it has bactericidal effects because, first of all, it increases the pH to a level that causes the cell walls to break down. But the hydroxide ions are also really, really tiny, that they can actually penetrate through biofilms. And unlike antibiotic cells, they're usually fairly large, and they don't actually penetrate deep into the biofilms. So apart from that, we also know that calcium hydroxide has some antifungal effects. It does have some hard tissue repair, which people have used for many, many years for either sort of pulp capping agents as well as apexifications. So in general, it is the most alkaline material used in endodontics. Now, so you've seen this slide from Laurie earlier. Well, E. faecalis is usually the bacteria that we tend to use in studies to determine how we kill, how effective a medicament or a material is at killing bacteria. Now, it by no means the only bacteria within the canal, but it is one of the tough bugs to kill. And think of it like a surrogate measure or a benchmark. If we can kill this bacteria, we have a good chance at killing a lot of other bacteria. So the reason why Enterococcus faecalis is so tough is because it's got actually a proton pump on its cytoplasm, and this acidifies the cytoplasm. So every time you throw at it, you throw something alkaline at it, it sort of neutralizes it fairly quickly. So the only way to actually kill this bacteria predictably is to have a pH of 11.5 or above. That way you sort of overwhelm the proton pump system that you can actually break the cell walls down. But this becomes a problem because you have the buffering effects of dentine, which becomes a problem as dentine buffers calcium hydroxide as it penetrates into the dentinal tubules. Now, if you start with a lower amount of calcium hydroxide, in terms of pH, you tend to have it buffer down to a pH of about 8 or 9 by the time it gets to the bacteria, which can hide very deep into the dentinal tubules. So one way to solve this problem is to actually start with a really high pH, like what Laurie showed earlier. You know, with Calmix, we can achieve pH of about 15 or 16 at times. And do keep in mind that pH is a logarithmic scale. So for every pH you go up, it's by a factor of 10. So this, early studies or early classical studies have shown that bacteria can hide up to 200 microns. In fact, newer studies have shown that this can even go as much as 500-600 microns. So we need to find a way to actually get the calcium hydroxide into this layer, but at the same time still be able to provide the effects that we wanted to do. And think about this, okay? This is an SEM slide of a canal wall that has been prepared, and you can see that that is the dentinal tubule. That is this average size of an Enterococcus faecalis. It's about half to 1 micron. So you can think, if you see that, it's pretty much like a highway for bacteria to just go straight in. So the reason why I tend to dress teeth between visits with calcium hydroxide is because I want to be able to have a material that can actually slowly penetrate into the dentinal tubules. You give it time for it to slowly diffuse through, and our studies have shown that, it takes about a week, sometimes even a little bit longer, for it to penetrate through into the dentinal tubules to about 500 microns. And at the same time as well, this study shows that having an alkaline environment actually reduces the ability for these bacteria to actually penetrate. So in the event you have, when you temporize a tooth, I would prefer to have a material in there that is very, very alkaline, so that in case there's any leakage, bacteria doesn't actually penetrate into the dentinal tubules. If you have another material such as an antibiotic paste, you may not get that effect, and you may actually get bacteria in the event of a leakage. It will actually penetrate in very deep, and once it goes deep into the dentinal tubules, it just gets harder to disinfect and clean. Now, everyone's always harping on the hydroxide ion effect, okay? I mean, that's pretty much the star of calcium hydroxide. And usually the calcium portion is just really a companion ion per se. But I just thought I'd put this in that, it's pretty interesting to see that the calcium ion can actually play a role. Now, our understanding of cystic formation and cyst breakdowns after endodontic treatment, it's still at a very rudimentary stage. I mean, we've got a lot of great literature on it, but our understanding is still not 100% concrete yet. But it goes to show that, some studies, this is a very recent study that shows that calcium ions may actually play a role in breaking down the epithelium of these cysts. And the authors of this paper actually recommended that we leave calcium hydroxide in for a long period of time, because you get the hydroxide ions that will actually disinfect the root canal system, and you get the calcium side, which can actually help to break down. So I thought that was just something that was really interesting. So just to briefly summarize some of the therapeutic benefits of a non-aqueous calcium hydroxide. First of all, it has a long-lasting effect, because you got a much higher pH content, much higher hydroxide content. You get this higher level of pH, and because it can maintain its pH, imagine as it goes through the dentinal tubules and it consistently gets buffered, by the time it gets to the bacteria, it will still be at a therapeutic range. Our hope is for it to be at that 11.5 range, so that it will kill bacteria such as Enterococcus faecalis even at 500 microns. Now, I like to just take a moment to remind everyone that you do have to irrigate with EDTA prior to calcium hydroxide placement. This is actually a slide of the canal wall after preparation, before using a chelating agent. So in order to get the calcium hydroxide to work properly, we have to open the dentinal tubules. Now, the dentinal tubules will be plugged up with a smear layer, obviously from all the cutting that we're doing with our rotary files. So you do actually have to rinse it with EDTA first. Just irrigate it for about 30 seconds to a minute with EDTA, and then you can go back to hypochlorite if you want to, or dry the canals and then put your calcium hydroxide. Now, I like to talk a bit about what's happening today. We're now moving towards a system whereby preparations are starting to get smaller. I like to call these preparations apical aggressive but coronal conservative. So in other words, we're trying to keep the apex relatively a size 25 or above, so that we can actually irrigate. That way we can fit the irrigating syringe down, but at the same time, we're trying to keep the coronal portion thin. That way you actually reinforce the tooth. I mean, the whole idea is to try and conserve tooth structure, because the more tooth structure you take away, the idea is that you weaken the tooth over time. So when we look at this concept, a lot of heat-treated files today with zero taper or like really minimal preparation taper, they're getting more popular, and you see them all over the place on the internet, social media, as well as all the different companies are promoting it. It is generally a good concept and it is a good idea. But we also have to remember that when you have something smaller, it is also going to be harder to irrigate. Looking at this image, the centerpiece is what you expect from a 30 gauge syringe. So assuming your normal irrigating syringe. Now, this can easily go to the apex of the tooth because they kept the apex fairly wide. But this becomes a massive problem if you have a curvature in the tooth. So if you have a curved canal, now this becomes an issue because irrigants only flow about 1.5 mils forward from the tip. And I assume everyone's using side-vented needles today for safety reasons so that we don't accidentally extrude. So because of that, you do want to have, in order to get good irrigant exchange and to actually flush out the bacteria and the debris from the apical region, we need to actually get our needle tips about 1.5 mils to 2 millimeters from the working length. Now that becomes a problem with all these small little canals or these minimal preparations, and it's compounded by the fact that very rarely you get canals which are straight as an arrow. They're always curved, and that becomes a problem because our needles are generally quite rigid unless we really, really pre-bend it really well. So there's a whole bunch of things that people have used to try and get around these issues, and some of which is using ultrasonic irrigation. So that way they use ultrasonic energy to actually irrigate and agitate the fluid. So hopefully that it will penetrate down into the apical region. This can be done with lasers as well, where lasers create shock waves to try and do that. You have a machine called GentleWave, which is popular in North America. I believe it's a $70,000 device that actually creates sonic waves to actually clean the teeth. All these are great, but we're coming back to this picture, which I showed you before. This was our confocal image to show that bacteria within this region is still not clean. And this was done using lasers. We actually used lasers to irrigate into the canal, to activate the irrigants in the canal. So if, unless you actually physically put an instrument in here, into the isthmus, it's almost impossible to actually clean these areas out predictably. Now, I think, all these different activation methods, they are great, don't get me wrong, but they are not exactly cheap, And I think for me, calcium hydroxide has worked for many, many, many years. And we know from the histological studies, the microbiological studies, we've known that it actually does kill bacteria. We know that it kills bacteria, it breaks down bacterial cells, it reduces lipopolysaccharides, so any of the endotoxins, it reduces inflammation. So yes, these irrigant activation systems are great, but we still have our old traditional medicament, which works, in my opinion, very well too. So just to briefly talk about the handling properties of it, not just from the biological side of things, but why I like this material. First of all, it doesn't actually dry out. You get a very long shelf life out of it. That's because there's no water in it. If any of you have ever used Pulp Den, I used to use Pulp Den in clinics, and the most frustrating thing is when you bring it out, the tip's always clogged up and it's all clumpy. And then when you try to give it a squeeze, the next thing you know, half the tube goes flying across the wall, across the room. So with Calmix, because we've taken water out of the composition altogether, the material doesn't dry out. No water, no dehydration. And because it actually doesn't clump out and it mixes so well in polyethylene glycol, it actually allows it to flow better through narrow tubes. And you can actually use really, really thin lumen tubes, which I'll show you in a moment, that can actually get to the apical region or the apical third of the tooth, which is exactly where we want the calcium hydroxide to be. And because it's more radio-opaque, we can actually see the material. We can actually see it on X-rays, and that's really good, like what Laurie mentioned, to be able to see it on X-rays so that in the event someone dresses a tooth and you take an x-ray, you know that someone's been in there before. But for me personally, we do a lot of apexification cases at times, and sometimes when we disinfect large open apices, we want to make sure that our calcium hydroxide is actually right to the apex. And lastly, it is also easier to remove. Now, this is a misconception because a lot of people think that this material is an oil-based material, but it's actually not. Polyethylene glycol is a universal solvent, and it's actually soluble in water. Although there is no solvent, there's no water in the composition, it does not mean that it's not soluble in water. So when you actually come to flush it out with EDTA or hypochlorite or even just saline, you'll notice that it flushes out a lot better. And that's because it is not actually mixed with some sort of a plant-based material, such as pulp then is mixed with cellulose in order to thicken it. Now, just before we wrap things up, I've always gotten a lot of questions on pulp capping. Now, this is not a pulp capping webinar, but I thought I'd briefly touch on it. So, there is an excellent paper written by Domenico Ricucci's group, which I really highly recommend people read it if you're into pulp capping. But in a nutshell, how we can use this material for pulp capping. So in the event that you have a deep carious lesion that approximates the pulp of the tooth, what these group of people have found is that a lot of times when the pulp is challenged, you get pockets of necrosis. You get focal areas of necrosis. It's not exactly spreading throughout the whole pulp immediately. So in the case that you expose a pulp from a carious pulp exposure, the pulp tissue can actually be relatively healthy below these areas that are close to the carious lesion. So they've sort of challenged the idea on our understanding on how the pulp can actually heal after you remove the insult of the bacteria. So really, success of pulp capping is really dependent on providing a very aseptic environment when we work. That means rubber dam, as well as good isolation techniques, but also complete removal of carious dentine. So the whole idea is if you remove all bacteria completely, you give the body a chance to fight back. And that is the sort of the biological basis of pulp capping or vital pulp therapy. Now, coming to the medicament side of things, like what do we use to put on top? So now you've removed all the bacteria that's there, okay? We generally put calcium hydroxide in the past because back in the 70s, it's found that calcium hydroxide can actually cause about 1.5 millimeters of coagulation necrosis of the pulp. Now, this is so-called a sterile necrosis. You've already removed all the bacteria. Now you're causing just a top layer of necrosis, but it coagulates the tissue. So you get necrotic tissue, but in a sterile field. And as well, the calcium hydroxide is caustic because it is high alkaline. It kills bacteria. It causes this necrosis. But because it's not liquefaction necrosis per se, where it causes everything to just turn to mush, it actually maintains its structure. But as it breaks down these tissues, they actually release certain growth factors that can help to stimulate repair, and that's where you get all these new laid down mineralized tissues. At the same time, the old necrotic tissues can actually form a scaffold for these new tissues to grow on. So the whole idea behind pulp capping is sort of changing with this recent paper and a string of recent papers from Ricucci's group to show that the whole idea is removing bacteria completely, then covering it with some sort of a material. Now the material, a lot of people talk about MTA, and MTA is a great material, but the basic block of MTA, when it sets, it releases calcium hydroxide. But the beauty of MTA is that it sets after it releases the calcium hydroxide. Now, you can achieve the same thing with something like Calmix. When you have an exposure or a pinpoint exposure, the trick, again, the key is to remove all carious dentine. Use carious dye detector or something. You have to remove all carious dentine. Then you cover that exposure with a bit of calcium hydroxide. But because calcium hydroxide paste like Calmix cannot set on its own, we will need to cover it with some sort of material such as flowable. I like to use Vitrabond. You can use GIC. In this paper, they use flowable. So once you put your calcium hydroxide, you cover with a flowable, and then you go on to do your restoration. So that way you can etch, prime, and bond without disturbing the calcium hydroxide. This is a bigger lesion that Rikuchi's group did. And they found that, once you remove all the carious dentine and the pulp is not bleeding tremendously and you can control the bleeding, they've actually used, in this example, they've actually used chemically pure calcium hydroxide powder. So it goes to show that the material is not really the deciding factor. But, we can use all these materials, but the whole idea is to have some sort of a calcium hydroxide MTA material on top of a clean aseptic field. That is the key. And in this image, we won't recommend it, but he did go back in just to show that mineralized tissues are forming in these areas. But obviously, we don't go back in, and you just layer it with your regular restorations and just review the patient. So these are some of the ways that we can do pulp capping, but I highly recommend you read the paper if you like to explore this further. So just to summarize, non-aqueous calcium hydroxide. It does enhance and prolong disinfection. It has deeper penetration into dentinal tubules because of its higher pH. For me personally, I like it from a clinical perspective. It is easily introduced because it has better flow characteristics. It doesn't clump up. It doesn't dry up. And you have these little tips that actually have a very flexible tip at the end. It's almost got a consistency of a fishing line, and you can actually snake this down to the apical third of the canal and backfill it. I use this tip on a daily basis, and it works really well in my hands. It's also easier to remove, like I mentioned earlier, because it is miscible in water. But more importantly, we need a solution that is both efficient, effective, and yet affordable for both our patients as well as for us as clinicians. So I believe, with Calmix, you can actually provide good endodontic treatment, good disinfection at an economical, at an affordable price. So I think that sort of sums it up on some of the clinical aspects or my take on Calmix. And that's it. I think we've got some time for questions.
We do. Thank you very much, Yao. So just a few people have asked about this, but you will receive a copy of the slides with your certificate of attendance. That'll be sent out over the next 24 hours. We have had some questions sent in, which we'll now go through. And if we don't answer these, then we'll do a little follow-up or wrap-up for that. You do have a little poll on the webinar, which has just popped up. So if you want to spend a minute just completing that, we'd be grateful, and then we'll start to work through the questions which have been provided. Yeah, I'll give you a moment to think about this one, but it's an extremely good question, very current for the current COVID pandemic. If an endodontic emergency appointment, what would be your first-line antibiotic for an endodontically involved tooth other than a pulpal extirpation?
Well, we don't want to look, usually with an endodontic infection, okay, the whole idea is to remove the cause of the bacteria. The cause of the infection, which is to remove pretty much the bacteria. Antibiotics are really a second line. I think, we've gone through this with the ADA and all that. You can do pulp extirpations because root canal treatment with a rubber dam and you wipe down with hypochlorite the tooth, you actually provide a very, very safe field to work with. But you do need to have very good aseptic techniques, which I think Laurie can explain further. But in terms of antibiotics, honestly, my go-to antibiotics is usually amoxicillin or augmentin. But I'd be hesitant to recommend antibiotics as the first line of treatment. It's really still a case of removing the cause.
Yeah, excellent answer. Yeah, and if we sort of think about the sort of general place of endodontics in emergencies, the ADA has developed guidance, particularly for people in Victoria and especially Melbourne, which is around the other types of restrictions. And there is now some more information provided on the ADA COVID website, which includes the management of things like endodontic emergencies. So that's been updated literally in the last 24 hours. So you might want to go back and check that website to get some further information there. There's a question here about how long you would leave Calmix in a canal for a case where there's a large cystic lesion, and would you be redressing? So this is a scenario that you've handled many times in clinic now.
Well, the thing is, I mean, if you want to look for radiographic changes, unfortunately, we don't really see radiographic changes for a couple of weeks to, well, technically months. Okay. For me, I tend to leave Calmix into the canals until the patient's usually asymptomatic. If you have a draining sinus, when the draining sinus goes away and you can actually predictably dry the canals, I think that's a good time to obturate. At the same time, if the biggest issue when I would actually redress multiple times, if I can't get the canals dry. And technically, I mean, when you have a big abscess or a cystic lesion, sometimes there's just a lot of exudate that you just cannot dry the canals. And that's the time when you actually put Calmix back in again, because the high pH will actually cause some sort of coagulation, necrosis to some of the tissues around the area too. And that works really well. There are times where you want to get the Calmix to the apex. So use one of those tiny tips, prep the canals a little bit bigger, get your Calmix down there, and then take a PA to actually see that you've gotten it down there.
Yeah, excellent question. So can you use, obviously you can use Calmix for pulp capping. What happens if you mix it with Letomix? And I'll let you answer, and I've got a spin on that question too.
I personally think there's nothing wrong with that. If you want the best of both worlds. I mean, there's conflicting studies in the literature that shows that Calmix can reduce, or calcium hydroxide per se, can reduce the efficacy of the steroidal component. But there's also a lot of literature back in the late 80s and early 90s from Professor Paul Abbott and Professor Jeff Hethersay down in Adelaide that have actually shown that a mixture works. I mean, definitely if you mix the two, your pH will drop. Ideally, I personally would use things separately. To me, the steroidal component is only good when you have a live pulp or you have a vital pulp, when you're actually removing tissues, and it's good for extirpation purposes. But when you want to have disinfection, you kind of want maximum hydroxide ion concentration. So I would probably use hydroxide ions. I will use Calmix solely once I've prepped the tooth.
Yep, very, very good. Would you ever use Letomix cement as a direct pulp capping agent? Remember, it's got that ZOE component in it.
That would not be my first choice, solely because zinc oxide eugenol is technically a tissue irritant to an extent, and you kind of want to create a very, very sterile field. So you get that with MTA because it releases calcium hydroxide, but it's mainly that the calcium hydroxide actually creates a very, very aseptic field. At the same time, it's been shown that the hydroxide ions, because of the high pH, can actually sort of break down a bit of the superficial dentine that releases some of growth factors that stimulate the formation of new mineralized tissues.
Yep. There's an interesting question which has been put in, which I might tackle, which is, do you get more post-operative pain if you have a higher pH? And there's actually good literature that shows that elevating the pH actually reduces the pain. That was one of the little tricks in the formulation of chemomechanical caries removal agents like Carisolve. Elevating the pH actually actively reduces the pain. However, when you have a readily or rapidly available pH, like with sodium hydroxide, if you extrude some sodium hypochlorite, there may be some sodium hydroxide, then you get obviously quite a severe irritant reaction. But that's the combination of hypochlorite and sodium hydroxide, not the gradual slow release of the calcium hydroxide, which is actually quite different, which is a very, very good and important point. How many days, would you normally leave Calmix in a canal in order to get that sort of deep, thorough disinfection?
I think from our study, we showed that it takes about, I'd say at least a week to 2 weeks, but usually after a week, we sort of get remember, our studies show that with the anthocyanin dye, it sort of peaks at around a week to a week and a half. So I'd say that would be the time. I mean, clinically, I usually rebook patients in for 2 weeks. So at least it gives it time for them to settle down. I tend to do things multi-visit because it gives patients a break. You know, you're not sitting in a chair for a long period of time in one go. At the same time, I get that extra disinfection during the inter-appointment visit. But I'd say a week at the minimum, but 2 weeks preferably.
If you had an apexification case, how would you choose between MTA and a calcium hydroxide?
Well, with a large open apex, I generally use MTA, and I think MTA is a fantastic material. But I would go to calcium hydroxide if I can't dry the canals. Because if you want to put MTA in, MTA can set in a moist environment, but not when it's flooding up with exudate or pus. So if you have that, then I would use calcium hydroxide first and make sure you get it to the apical third, leave it there, review the patient. If you can sort of dry the canals, then I'm pretty much set with the MTA. But MTA will be my choice first for that.
Yeah, good. When you're using the Calmix, are you spinning it down? Are you backfilling it, injecting it? How are you doing it?
I like to use those tips that I showed you. They call it, I believe Osden calls it the micro tips. I think they're very good because you can actually put it down to the apical third, and because they're actually quite flexible, you can actually easily snake it right down to the apical third.
Yeah, good.
And backfill it.
Yep. So there's a question about, can you use Calmix in deciduous teeth? Where would you use a calcium hydroxide in a deciduous tooth?
For disinfection, you can use calcium hydroxide, but generally, as the tooth, I mean, a lot of times with deciduous teeth, the aim is to sort of keep the tooth there just until the permanent successor comes along, but you don't want to disrupt it. I think if you keep the calcium hydroxide to disinfect the canals, but within the confines of the tooth and not to extrude it, I think that's acceptable. I'm not a pediatric dentist, so to be honest, I'm not too sure on that front.
Yeah, that's good. Question about will calcium hydroxide denature the collagen? Well, the studies that I showed you, which have been conducted on strength testing, indicate that it doesn't weaken the structure of the teeth, so it's not actually denaturing the collagen. So it's actually a bit more subtle than just the pH. It's actually about the rate of delivering the calcium hydroxide ions that seems to be really, really useful and important. Yeah, we're almost at time. I think we've got time for one question. There will be some unanswered questions. So what we will do is we will go through those and prepare some answers, and they'll be made available through Ausdent. So don't worry if we haven't got to your question. We will endeavour to handle those a little bit later on. I'd just like to come back to the question about mixing it with Letomix, because there has been some recent research done on that. Just remember that when you mix things together, that you bulk dilute both parts. So you end up with two diluted materials. And if you're trying to get a bit of both worlds, which was the original concept, then that's perfectly fine. But you need to think about what is your key therapeutic outcome, and then maybe choose materials that actually go exactly with that. Ladies and gentlemen, thank you for your participation and involvement tonight. It's been very great for us to be able to spend some time talking with you. There's been a very good attendance tonight, and as a result, we do have quite a battery of questions, around about 30 odd, that we haven't had a chance to answer yet. So we will endeavour to go through those and make a little response to that, which we can share with you later on. Thank you so much for your attendance tonight, and please enjoy the rest of your evening, and I will bring this evening to a close. Thank you very much.